Good evening, all the delegates and faculty. On behalf of the organizer, I welcome you all for today's meeting on masterclass lecture on supportive care in acute leukemia. Without wasting any further time, with the permission of the organizers, we will start today's proceedings. Now I introduce Dr. Devmalaya Bhattacharya, teacher for today's meeting. He is a consultant, Department of Hematology and PMT, Apollo Multi-Speciality Hospitals, Kolkata, India. Over to you, sir.
Good evening, everyone. So thank you, ISBT, for giving me this opportunity for taking this master class. And my topic is today, supportive care in acute leukemia management. So this is actually a very important topic. Why? Because we know leukemia treatment consists of some chemotherapy and some high-end medicines for which there needs a mix and match of medicines, combination therapy for this. But problem is that the supportive care many people forgot. When we used to study, we are not aware of the supportive care. Why? Because supportive care we were not that much read in our textbook. What we read the chemotherapy combinations, mechanism of actions like this. And for this is a very important topic. And I have made the slides very simple because I don't want to discuss some guidelines or some other things which are already written in some books and journals. This is the age of internet, so we can always have some downloads and read on the data. But I like to share some of my experiences and problems I faced during our daily practice. So I will start on next. So the variation of leukemia, acute leukemia, there are two subtypes. Next. One is acute myeloid leukemia, another one is acute lymphoblastic leukemia. So these two leukemias are actually very different types of needs, different types of approach and treatment. And obviously, this acute myeloid leukemia is more dreadful, and the patient is kept inpatient. So patient remains long in hospital for treatment purpose, and there is very much morbidities and mortality with treatment of AML. Whereas on the contrary, for ALL patients, it is relatively different. The patients remain relatively stable, both inpatients and they may need inpatient chemotherapy, and at times they need outpatient chemotherapy. So for this, the treatment varies. Why the treatment varies? Because the outpatient patients who are being treated on outpatient basis, they may not be that easy to see daily basis, or what is happening in their house or in other places. We don't know as a doctors. At least we as a consultant, we can never know. That is a problem. So so the supportive care in those patients is relatively different. Why different? Because we may not be knowing what is in the background, what is happening, what is the problem with the patient's family, what are the financial background, what are the issues like that. So what is supportive care? Supportive care, the support can be from different pillars of during hospital or treatment management. One is from medical perspective, another one is from transfusion part. Blood transfusion is a difficult thing nowadays, especially in non-government hospitals or private hospitals. Antibiotics and prevention of infections or preemptive measures, central line or PICC management, comorbidities management, nutrition or diet, that is very important, and above all psychological support and financial and logistics support. So these are the things which I deem fit for discussions during this class for management of acute leukemia on supportive role. So those, so we know the actors are different, but the supportive actors, they make the film. So this is very important. So I am not going in wasting time. And there are few guidelines which tells us about the different protocols or regimens. I'm not going in details of those. Now, medical team support is very important because this is the main base of your treatment. Why base? Because everything is there, but there is no proper medical team. This is the treatment will be a complete failure. And obviously, this treatment cannot be handled by a single doctor. Now, listen, this is the era of aura among the main chief consultant is nowadays over. So, medical science is treatment of any patient is now a team effort. So, you can never blame or give the credit or discredit to a single person during leukemia treatment, because the treatment is long term. One single doctor can single-handedly cannot manage day-to-day treatment planning and other setups. So combination of consultant, RMO or duty doctors, chemotherapy nurses and intensive care nurses are the most important pillars of your care. And role of consultant is relatively less in all treatment plan, because the consultant gives around 10 minutes, 10 minutes twice daily maximum, and consultant gives the opinion. But the execution of the work or execution of the procedures, sampling, collection of blood, giving proper injections or in timely chemotherapy, prevention of extravasations. So these are the main things which should be handled by the lower tier staff. This is very important for a successful running of hospital. You need a group ground good number of ground people who work on the ground level meticulously and sincerely with a proper training and expertise. So, for example, if the RMO duty doctors fail to do some information, passing of some information like fever, temperature, or neutropenia reports, so this will be a failure on their part. Another thing is the chemotherapy nurses. If the chemotherapy nurses cannot assess the IV cannula status, how whether it is properly infected or not, that is also the failure. Now, intensive care nurses, they are important because in many times the patient require ICU admissions, and for those people, many times we have seen that PICC was good, was functioning well. Patient was shifted to ICU or HDU for some severe hyperglycemia episode, and after the patient comes back to the ward, the PICC line or the central line is blocked. So this is because of the carelessness of the people handling in the ICU. Why it is callousness? Because they may not be properly have maintained the patency of the tube by of the line by proper timely infusion of heparin, heplocks like that. So this is very important. Now, another important part of supportive care medical management is the proper passing of information. So this is a duty of the duty doctors to collect the report in time and inform the consultant or the concerned person at the earliest. And critical report notification. This critical report notification is also important part from the lab aspect. The lab people, whenever they found something unusual or something critically low or critically high, they should inform the duty doctors or the consultant directly, so that there should not be delay in the intervention. Suppose I'm giving some examples. Suppose the patient's WBC count is 630 and the critical report was missed, and you have given the chemotherapy on that day for cytarabine in ALL. So that is a mistake. So you should not do that. You should be more aware of while passing the critical report info notification. And also for the for other things, suppose the SGPT, SGOT is high, or the sugar level is high, or sometimes in the relapse patients, the reappearance of the blasts. So these are the very important things which can be done. Now, another point from duty doctors or medical team is the early detection of the medical emergency. Suppose the patient is having some high blood sugar level or some pancreatic pain following aspergillus infusions after a few days. So these are the medical emergency in ALL setup. So these are the things you should pick up in timely, in proper way, and inform the consultant. So these are the many things which are required on the supportive role by the medical team, especially the detection of the medical emergency. Because if you not act in time, there will be you may lose the patient. And timely intervention. After informing everything, the consultant advises, and the medical team and nurses, they should immediately execute the advice of the consultant. This is also important. Suppose the consultant has written some antibiotics or urgent ultrasound, but you are doing it after 6 to 8 hours. So then the advice will have no value. So for this leukemia treatment management in the induction phase, the time is gold. Next. Now, I have made a specific portion that is called febrile neutropenia. Febrile neutropenia is a dreadful complication of leukemia management, and this febrile neutropenia should be managed in very active way. Say, you should do you be very hyper. I must tell the resident doctor nurses should be very hyper to prevent this complication. So what is that? The detection and assumption of the neutropenia is most important. Suppose if you should always doubt or guess chances of neutropenia. Now, another point is that golden period of febrile neutropenia, the first 1 hour of having a fever or the more than 100 degrees Fahrenheit is very important. At times, we may not give the degree of fever because many neutropenic patients, they may not have a full manifestation of the fever. And IV fluid maintenance, checking of the urine output is very important. And along with that, the choice of antibiotics according to the hospital policy or the local guidelines is also important, because we always follow the Western guidelines. We may not be that good in following the Western guidelines, because we should make our own guidelines, because India is a subcontinent, and in many big hospitals or teaching institutions, we follow the main our local policy wise antibiotic policy, because in some setup the piperacin tazobactam is a primary antibiotics in febrile first dose. Even in some places it is cefoperazone sulbactam. Anyway, one broad spectrum antibiotic of choice according to the local policy should be administered. And this first dose of antibiotic is very important. You should draw a blood culture before that and send it to the lab. And also, information from the lab is very important. If there is any growth after 1 day or 2 days, that should be important. That falls into the category of passing the information in proper time. So this is very important, and there are many guidelines for management of the febrile neutropenia. So this is very quite needful thing, and of primary concern. Primary concern is for the duty doctors and nurses. Now, another big point in leukemia is transfusion support. Obviously, it's a blood cancer, so there will be always a need of blood transfusions frequently. So off and on, it is required. In AML patients, the blood transfusion is very continuously. It may be required daily or alternate day blood transfusion is required, because AML induction is a very sophisticated treatment plan, and you should be very cautious while treating these AML patients during the induction phase. So AML induction is very important. And cutoff of hemoglobin, we usually 8 gram or platelet less than 20,000 is the usual standard, but there is some variations, like in acute promyelocytic leukemia patients, we keep a platelet threshold more than 30,000 at least, and in bleeding patients, we try to maintain it more than 50,000. But it is very often, it is not possible in that way. So in those cases, we have to do the customized treatment, not according to the guidelines, but definitely we should not over transfuse the patient. Overtransfusion is very problematic. You may land up into trouble during overtransfusions. You may have uninvited or unwelcome complications while when you will be doing overtransfusions. And another point or hazard is the platelet refractoriness. It's a very common problem, because the patients mostly given RDPs, or random pool donor plasma platelet, and these random donor platelets cause increased refractoriness. So when whatever platelet you give, there will be no increment in the platelet count. So we advocate HDP transfusions for those patients, but often it is not applicable in every scenario or every setup. HDP is difficult to procure or to make. And another point is that for a suitable donor may not be available at times. And another point is transfusion related hazards. This is also very important, because this transfusion is a complicated process. Many doctors or nurses, they take transfusion very casually, but this and leukemia patients who are frequently transfused, it is not a matter of easy thing. So this has to be managed. You should take information from your transfusion medicine experts or blood bank experts. That's why, because many times we may miss the minor mismatched transcription reactions, or we may have we may face some trally following infections because the patients get heavy treatment for other therapies. There may be fluid overload pre-existing, and always you should prevent or avoid, better to say, nighttime non-emergency transfusion. If the suppose the patient is hemoglobin is 4 and patient is bleeding, that time you always do the transcription in the night time. But if the patient is bleeding, hemoglobin is 7.2, patient is stable, there is no need to do on hurry nighttime blood transfusion. You should do it after in the morning time. So these are the main things for blood transfusion support that you should always be very cautious and take whenever you have any problem, you face any problem, you should take help from the transfusion medicine experts. Now, next is central line or PICC care. This is very important. We may not face this in ALL patients very often because adult ALL patients, they seldom require PICC. But yes, at times they require. But for these AML patients, we always prefer to do one central line because of the daily sampling and chemotherapy, number of antibiotics to be given for those things. And essentially, it is an essential thing for long-term treatment, and it gives much comfort to the patient. So for patients care, because many patients, they are irritated. This is quite natural. They are quite irritated with frequent sampling and putting IV cannulas, having pain, thrombophlebitis, all these things. For those patients, it's of very big boon that some long line has been kept properly. So, and it is of very help if you give some corrosive chemotherapy, where the chance of extravasation is very high and it will be complicated. In those patients, we always, this long line is helpful. Next one is PICC, proper expertise in handling of PICC. I was talking before that you should always do one proper handling of the PICC, maintenance of the patency of the PICC, and prevent PICC related infections. Antibiotic lock culture from the PICC is required, and very often you should not be very prudent to remove the PICC. For central line or jugular line, you can remove it easily, but for PICC, it is very costly. And the main purpose of the doing PICC will be lost if you remove it prematurely, because PICC should be there for a few months so that the cost will be worthy. It will be cost effective. But if you mishandle the line and there is a PICC related thrombus or infections, then you have to do. That's a very unfortunate scenario. And the removal of PICC is required if there is some thrombosis or some bad bacterial infection like staph, pseudomonas, or enterococcus infection, and the patient is very much febrile. For those patients on those scenario, we should always do removal of the PICC irrespective of the time passed from the introduction. Now, management of comorbidity. So this is a term we often miss in the initially, but this management of this comorbidity remains very important, because the pre-existing diabetes and hypertension, especially in the elderly age group, is of much concern, because the treatment protocols mostly involve steroids in acute leukemia, and this for this steroid help uses, the chance of hyperglycemia is very high, especially in the diabetic patients. Even if the patient is not diabetic, then also there is chance of steroid-induced hyperglycemia even in the pediatric age group. Also, we have seen many obese patients or in many young children who are suffering from steroid-induced hyperglycemia. And another point is that avoidance of the nephrotoxic drugs in patients who have having early CKD, like you cannot use amphotericin B or some long-standing amikacin for those patients whose creatine is quite high. So this is also of concern, because at times it is difficult. And early suspicion for pancreatitis in ALL patient receiving steroid and elastoplast is also very important. Especially in the pediatric age group, there is chance of pancreatitis following elastoplast. So you should always do the lipase, amylase, ultrasound, and other markers like CRP to find out any pancreatitis early. And this comorbidity is it's more complicated while there is steroid-induced hyperglycemia. Another big problem we face during our treatment is drug-induced hepatopathy or transaminitis. I am now presently I am dealing with one patient who is having ALL patient with transaminitis, and probably it is due to drug-induced. So this is very challenging for us to do these things, and often we have to defer the chemotherapy. We may not take the may not be able to do timely chemotherapy. So that is a challenge and drawback of the comorbidities, because if you give chemotherapy, there will be a further aggravation, there may be other problems. Another problem is drug-induced venous thrombosis. The main problem, main causative agent is obviously L-asparagines. Also, it can occur with virtually with any other therapy, but due to low platelet count, we usually don't face much in AML patients. But for ALL patients, thrombosis is especially venous thrombosis, sagittal venous thrombosis, intracranial thrombosis is very dreadful nightmare for us. But proper diagnosis of the thrombosis, early diagnosis, if it is PICC related thrombosis, you may have to remove the PICC and do proper anticoagulations with proper dosing. So these are the co-management of comorbidities. Among these, drug-induced transaminitis and steroid-induced hyperglycemia are more very much common in our practice. And you may take help of insulin to control the blood sugar, because if you don't control the blood sugar, there may be increased chance of infections in those patients. Then comes the nutritional support. So nutritional support is also very important because it is an essential part of leukemia management. Long-term muscle protein loss is a potential adverse effect of AML treatment, because the patient remains in hospital for a long time, takes chemotherapy for a long period, had chemotherapy-induced problems. And for ALL patients, there will be weight gain and obesity due to long-term steroid usage, because in induction and re-intensification phase of BFM protocol, there is a good amount of steroid given for a long day. So these are the things which can cause weight gain and obesity for ALL patients. Mostly we see many patients who become obese after the therapy, and many patients who become cachectic after therapy. But the cachectic group is usually they belong to the AML group, and those patients suffer from mucositis and CINV, that is chemotherapy induced nausea, vomiting. And this is a challenge for the pediatric age group people to maintain a good nutritional balance, because pediatric patients, we know they are very difficult to convince about their disease. So and there are many tantrums, it's quite natural in that age group. So to maintain a good nutritional balance is very important as well in pediatric age group and also in the elderly age group, because of the mucositis and other issues. There may be depression in the patient, so he will be not able to take food. Many patients, they just do vomiting, start vomiting after seeing any injection or gloves, injection or syringes like that. So these are the potential effect, but you have to maintain a good nutritional support, because long-term treatment there will be muscle loss. If you don't replace the proteins in proper amount, there will be loss of cachexia and other problems. This is very important. Another point is mucositis during methotrexate consolidation in ALL patient. In those patients who develop severe mucositis, you may opt for parenteral nutrition. But in ALL treatment, we seldom need total parenteral nutrition, because the mucositis is not that long-standing, except in the relapsed refractory treatment group. In those patients, as the chemotherapy dose is higher, there may be mucositis, more mucositis, and or in that group which where use the hypersevere protocol, or we use the RAISE protocol, that is the relapse refractory or high risk ALL patients. So regular visit by the nutritionist is essential, because the doctors cannot manage this by measuring the calories, calorie deficit, everything, the food calories. And so this is not a job of daily job of doctors. Obviously, they will give their inputs, but the main job is by the nutritionist. Now, psychological and social support. Initially, we used to laugh at this point, because at many times we knew we were superior, we are doctors, so this is not a big job. We had that attitude during our initial student days. But actually, this is very important, because the psychological and social support is very important for successful completion and continuation of the chemotherapy, because the treatment is long term. 6 months to 2 years of treatment is not a matter of joke, and there is gross psychological stress in every level during this treatment plan. Especially, mostly it is highest during the time of diagnosis, or during the time of chemotherapy induced nausea, vomiting, or if the patient develops some complications. So these are the very important stress. And another new stress or more aggravating stress is when there is relapse of the disease. So these are the main things which we should take into concern. And the steps are the psychology counseling is must. I personally prefer psychology counseling for all patients at diagnosis, because they may not be that frank to your doctors initially, to the consultant doctors initially, but maybe more friendly with the psychologist, because the job of psychologist is to convince the patient. So psychologists are much more mentally close, emotionally attached with those patients. And there are many social groups which can help in the help, especially for the children. They may play with them and relieve out the stress and also for their parents. And this support, social support and psychological support, they also take care of the academics in children for long-term treatment, because many patients study, many children studies suffer a lot because of the long, especially for the ALL patient, the treatment is 2 years long, and there may be intermittent neutropenia, fever, disruption of normal life. So in those patients, the academics is also, maintenance of the academics is also very important, and that keep the patients, the children in child in good shape mentally. And another important point is financial and logistic support. And this is, I think, this is most important for acute leukemia management. Assessment of the financial reserve and status and the other logistic support is very important while before beginning of chemotherapy. Loss of many patients, there is printing missing, loss of many patients due to these reasons, because if you work in a medium poor or resource poor setup, we lost many patients due to this financial and logistic disease. Patients go to their hometown, take some Ayurvedic medicine, and ultimately die. And there are many NGOs who help the patients. You have to inform the patients about this. And logistic support, they may take help from peer group. Maybe they are often in many hospitals. There are patients support group. Even the patients' relatives or parents, they have made a group. They do some WhatsApp group and they help each other. So these are the new good things for these patients. Another one is the hospital social service system. They also a group which helps the patient, especially it is more required in the first 1 month of treatment, because the patient's family is is not new to the hospital, is not closely attached with the hospital's policy system. So in those patients, so that they don't get nervous, for those patients, this hospital social service system is also required. And another important thing is the unemployment of the parent due to long-term treatment, because there we are doing living in nuclear families nowadays. So there may be unemployment of father or mother, they, because they cannot go to the job for attending the patient, their children. So these are the things which are quite difficult to manage at times. You may manage with leukemia, chemotherapy, medicines, support, transfusion, but these are the financial and logistic support. It is at times it is beyond doctor's reach or ability. And also you can tell the patients for government funding help. Next. Now the take home message from this supportive care is very important. Yeah, proper medical support is of utmost importance, and optimal transfusion and antibiotic support is required during all phases of therapy. Educate and train the healthcare personnel dealing with intravenous catheter or PICC line. Management of comorbidities, take help from other specialists, especially medicine and gastroenterology is very important. Financial support, psychological counseling, and throwing of positive hope is very important. So thank you for your patience hearing. It is a difficult thing because, but mostly it is a subjective understanding on my uh, part. So thank you all, and you can ask any questions if you are interested.
In your Apollo, how much patient you faced the fungal infection after the chemotherapy, and how do you treat it?
In ALL patients, rarely face fungal infections, but for AML patients, we very often we face fungal pneumonia in AML induction patients. But all those patients we used to give, we are used to give voriconazole prophylaxis, and the patients who have probable fungal infection, we start of amphotericin B or caspofungin.
What is the nature of the fungus? Have you
we see Aspergillus mucor. Luckily, we don't see that much.
Okay. Secondly, how much CMV infections you have found in the after the chemotherapy?
Sir, we usually don't found. Another minus point is that we initially never search for CMV because the immunocompromised status is not that long, except for AML induction. But in those patients, especially when there is no response to other antibiotics, then we search for CMV.
Right. After the giving drug, how much cardiomyopathy you have seen?
Sir, this
Drug
is,
induced. Drug
this is
induced.
difficult to tell because there may be confounding factors, other contributory factors. But per se during chemotherapy, because in induction phases, mostly the hearts are normal before baseline. So we don't see cardiomyopathies. But for elderly age group, we usually reduce the dose. So that may be another reason that we don't see this cardiomyopathy.
Thank you.
Okay, sir.